record. Good evening, everybody. In the series of varied, teaching inputs, one of them is a faculty lecture. Today, we have the good fortune of having Nishant, young and upcoming surgeon from Shanti and various other hospitals, to talk to us about approach to parotid surgeries. I think the variety of teaching tools will help drive home points which sometimes may not be possible in one form or the other. So I think faculty lectures where the input from from more experienced people, in addition to then asking questions in between and try to probe the student's mind. I think that is also a very good form of teaching. So I would invite Nishant to start his lecture. Thank you.
Thank you so much, sir. Hello and good evening, everyone. So in today's class, we are basically going to learn approach to parotid surgeries and of course, in detail about how to operate, what are the small nuances. So in short, basically this will help you in your exams, be it theory or practical. So we will concentrate only on those points with a lot more care. To be very honest, my numbers with Parotid is very bad. Okay, I had brought this to the notice, and maximum probably I've assisted in about 10 or 15 cases, but not beyond that. So my knowledge for this particular topic is from varied papers, textbooks, and of course I did consult 2 or 3 head and neck surgeons, and I've got inputs from them as well. And it's a compilation of all of that. So first, all you need to know is that the parotid is a gland, it's a salivary gland, which is situated within a bony network. Of course, you will have certain bony landmarks for that. So that skeletal background is important. So posteriorly, it's the mastoid bone. Anteriorly, it's the ramus of the mandible. Medially, it's the styloid process. And posterior superiorly, you're going to have the external auditory meatus or the external auditory canal. So in short, your parotid gland is somewhat situated like this. All right. So you just need to know what are the bony landmarks first, because all these are important when you're operating, because all these are important landmarks for you, which will help you identify the facial nerve. But in the exam, if they ask you what is the parotid area or the boundaries of the parotid region, or in which area the parotid gland is situated, then you will have to say superiorly it is the zygomatic arch. Inferiorly, it's the sternocleidomastoid. Anteriorly, it's the masseter. And posteriorly, it's the external auditory canal. So if you look here, you can see superiorly, it's the zygomatic arch. And like I told you, this is where the parotid gland is situated. That's the duct. So inferiorly, you can see it's the sternocleidomastoid, which is here. Anteriorly, you're going to have your masseter muscle. And posteriorly, you're going to have your external auditory canal. So these are the boundaries of your parotid region. Now, one quick question. Why are we only concentrating on parotid? Why not submandibular gland, sublingual gland? Now, the answer is pretty straightforward, because here facial nerve comes in between. All of us are very concerned about the facial nerve and the morbidity associated with injury of a facial nerve. But why is it that we even have two lobes in the parotid? Postgraduates, anybody?
Sorry, sir. Question.
Pardon me?
Why two lobes?
Yeah, why is it that only parotid has two lobes? Why is this not there with, let us say, submandibular gland? Now we know that submandibular gland has lingual nerve, hypoglossal nerve associated with it, but why doesn't the nerve run through the gland? Why is it only next to it in submandibular, whereas it parotid, all these structures run through the parotid?
The lobes, because of the plane, sir. This arteriovenous plane.
I know, but why? Why is it like that? That is what I'm asking. See, I understood what you're telling me. Superficial temporal artery is there and it runs inside the gland. I'm asking why should it run inside the gland? See, here also you have facial artery close to the submandibular gland, but why doesn't it run through the submandibular gland? Why is it adjacent, but in parotid it is in the center? Anybody else?
Sir, because the encapsulation occurs very late, sir.
Excellent answer, Samir. So basically what happens is when you have a gland, you have the secretory part of the gland and you have a capsule surrounding it. Now the secretory part is what arises from the ectoderm. All right, so gland per se arises from the ectoderm, whereas the capsule arises from the mesoderm. So normally the gland comes and then you're going to have the mesoderm or the mesenchyme which covers it and you're going to find an encapsulated gland. But what happens in parotid is that encapsulation happens at a very late stage. So when it is not encapsulated, that is when all the structures such as your artery, vein, and nerve run through the gland and the encapsulation happens after that. That is why that is something which is peculiar to the parotid. And that is why all of us are only concentrated on parotid and we don't think too much about the submandibular or the sublingual gland. Now, one important question in your exam is what is the order in which these structures are arranged from deep to superficial? It's the artery, then the vein, then the nerve. Now, the clinical importance of this is that, let us say you're operating on the parotid and you start seeing an artery or the vein there, the retromandibular vein or the superficial temporal artery. In short, all it means is that you have cut through the nerve and then you're looking at these structures. That means you have already caused the damage. So don't assume I'll find the artery, it's in the same plane. No, the nerve is the superficial most structure. So you have to be extremely careful. Only after the nerve will you encounter the other two structures. So, like I said, a little bit about the facial nerve. The facial nerve arises or it comes out into the external part through the stylomastoid foramen. Then it divides into two branches. Okay. The upper one is called as the temporofacial. And the lower two branches are called as the cervicofacial. Now, this split where it happens into those upper three and lower two branches, this area is called as the pes anserinus. Can someone tell me what this means? Or what is the literal meaning of this term, pes anserinus? Go for it, Praveen.
Goose food, sir. Goose.
Correct, correct. Where else do you find this terminology? Homework for you guys. Please let me know where else in the human body do you find pes anserinus? All right. So basically, that's how the feet of a geese or goose looks like, and that's why they call it as a pes anserinus. So multiple areas in the body where you're going to have split like this is called as the pes anserinus, which is the actual the actual meaning of the terminology is basically goose feet. Now moving forward, there is one surface landmark that you guys need to know, and that is called as the Zucker point. Anyone, any idea what this is or what it is suggestive of?
Sir, this is for Stunsen's that identification, sir. Palpation.
Close by, but in reality, Zucker's point is basically for the buccal branch of the facial nerve. The buccal branch. So what they do is they're going to draw a line from the tragus all the way to the angle of the mouth, find the midpoint, and they say this is where you're going to identify the nerve. Now, can anyone tell me why we are doing this? What is the clinical importance?
Retrograde identification most commonly.
Exactly. So in case you're operating on a recurrent tumor, the planes are not correct and you're forced to go retrograde. So that is when you go there, find the buccal branch and go backwards. Okay. Now, the second thing is regarding Stenson's duct. We will talk about it later, but I'll cover it right here. Can you tell me the surface marking for the Stenson's duct?
Along this line only, sir, anterior, posterior,
1/3.
posterior 2/3 and anterior 1/3.
Yeah, see, that was the old one. Now the recent one, they say, is from the tragus, they're going to draw a line to the midpoint of the upper lip. Okay. Of course, the other way of remembering it is find the midpoint between the ala nasi and the angle of the mouth. Then draw a line from the tragus to the midpoint of these two. Technically, it goes to the same area. Okay. And the middle 1/3. Middle 1/3 is where you're going to draw the Stenson's duct. So middle part of the upper lip and the mid 1/3. So in case in the exam, the examiner doesn't agree with the middle part of the upper lip, like I told you, tell it's the midpoint between the ala nasi and the angle of the mouth. Again, all these are only for your exam point of view, but practically not important. Okay. Now, there is another important nerve that we are concerned about, and that is the greater auricular nerve. Now, there are two things that you need to know about the greater auricular nerve. First and foremost, it is a sensory nerve. Second is that it has two branches. Okay. The one is anterior, one is posterior. You can see here, this is the greater auricular nerve. It arises from C2 and C3. You're going to have a posterior one which runs behind the ear and the anterior one which runs in front. What is the clinical importance of this? Anybody?
Nerve damage and anterior is the most commonly damaged nerve, which leads to post surgery loss of sensation over the ear lobe.
Okay. And one more. Do you know another one?
We will use the posterior branch for the reconstruction.
Okay. Close by. See, simple, common sense. Parotid incision is like this, correct? And the anterior branch runs over the tail of the parotid. So if you have to reach the parotid, invariably you only have to sacrifice the anterior branch.
Yes.
Okay, it's not that it gets damaged. You voluntarily sacrifice the anterior branch in order to gain access to the parotid gland. Now, the idea is try and save the posterior as much as possible. And second thing, like you said, is for graft. Okay. Whenever you are doing a facial nerve graft, you're going to use this. And the reason being, one, it's in the same incision and you don't have to open up or get another nerve from elsewhere in the body. And second thing is the thickness. The thickness of this greater auricular nerve is somewhat comparable to the thickness of the facial nerve. So your graft becomes that much easier. That's the reason we don't try to choose another nerve. Can you tell me another nerve which can be used, which can be sacrificed and can be used as a graft? First one is a greater auricular. Second one, can anyone guess?
Posterior auricular nerve.
Hey, that is part of this one only, man.
Sorry, sir, I didn't get the question.
Can you tell me another nerve which can be used as a graft for the facial nerve,
Sural
which
nerve
can be
and
sacrificed? Yeah,
sural nerve.
sural nerve is the answer. Okay, sural nerve has slightly a bigger thickness, but again, that is a nerve that can be sacrificed, which is easily identified and can be easily harvested. Do you know where to identify the sural nerve?
Sir, posteriorly close to saphenous.
Which saphenous? There is greater, there
Great,
is
greater one, sir.
Lateral
great.
malleolus,
Sorry,
sir, along in the short saphenous vein territory.
Exactly. Vinod, with the greater saphenous or
Sorry,
the
yes,
long
sir.
saphenous vein, you're going to get the saphenous nerve.
Saphenous nerve.
With the short saphenous vein, you're going to get the
Sural
sural
nerve.
nerve. It's behind the lateral malleolus. You just make an incision. Apart from tendo Achilles, the only other long structure you're going to find, which is not a vein, is the sural nerve. Okay. And you can harvest how much ever long segment you want and then use it for the facial nerve graft in case it is needed. Now we know that the parotid gland has certain lymph nodes in it. Now the lymph nodes can either be in the superficial lobe or in the deep lobe. Now 90% of your lymph nodes are in the superficial lobe. Okay, 90% are in the superficial lobe. And the areas which these lymph nodes drain are your pinna, the scalp, the eyelids, and the lacrimal glands. Then 10% of them which are present in the deep lobe. Okay. These drain the other areas such as the parotid gland itself, middle ear, nasopharynx, and the soft palate. Now, can you tell me what is the importance of having this piece of information?
The lymph nodes which they pass, drain.
No, that I've already told you, but I'm saying what is the clinical relevance for it? Anybody else? Nikita, Praveen, anybody?
No, sir.
Okay. One thing is to look for metastasis from these regions. Okay. If there is a malignancy of the pinna, the scalp, you can expect the lymph nodes to come here. Okay. And second thing is there is something called as what biopsy is that? Frozen section or your sentinel lymph node biopsy, where the first lymph node you're going to drain. Oh, sorry, the first lymph node which that particular area drains will be taken out and sent for testing, correct? So if you're suspecting a malignancy in this area and you want to know whether it has spread, you have to do a superficial parotidectomy for these particular areas. Or if you're suspecting it arising from these areas, then you will end up doing a total parotidectomy, or you will have to remove the lobe or the deep lobe of the parotid. Please note, you can't individually take out the lymph nodes. There is no role of that. Either superficial parotidectomy or a total parotidectomy. All right. So that is the importance of knowing this. Of course, this is extremely rare, but you should be aware in case they ask you in your exam. All right. So then Stenson's duct, we've just already covered it there. Okay, just one extra point that you need to know. What is the structure that the Stenson duct pierces? We'll ask the first years. Samir? Samir, you're there?
Yes, sir.
Yeah, can you tell me what are the three structures the Stenson's duct pierces? B.
Sir, buccal mucosa, buccinator, and
Buccal pad of fat.
Excellent. Buccinator, buccal pad of fat, and buccal mucosa. And can you go on and tell me where is it exactly that we find the opening of the parotid duct?
Upper second molar tooth, sir.
Crown. Crown of the second maxillary molar. Maxillary in short basically means your upper molar, just different terminologies or little bit the different way of telling it out. All right. Now, the other last point that you need to know with regards to Stenson's duct is that it is in close proximity with one branch of the facial nerve. We've already discussed this, but again, first years, can you just reiterate that? Which is that branch of the facial nerve that it's in close proximity with?
Come on, guys.
Hey, very straightforward. Answer is here only.
Buccal branch.
Zygomatic or buccal branch, sir.
Buccal branch only. Okay. Another important point is that if at all you have to sacrifice a nerve, which will one branch of the nerve, choose the buccal because that is the one where you have the least amount of morbidity. Okay. But anyway, idea is not to do all that. Now, the reason why I brought this up is when you're doing superficial parotidectomy, when you try to ligate the Stenson's duct after you do a superficial parotidectomy, please be careful because the buccal branch is in close proximity. Sometimes you might entangle that and cut it off as well. So that is why you need to know that the buccal branch is in close proximity to the Stenson's duct. Now, just a quick run through regarding the physiology. Of course, this is already covered, so I will just run through it. Okay. I'm sure most of you already know it. Stones are more common in the submandibular gland. Okay. Calculi are more common in the submandibular gland. And the reason being, submandibular gland has to pump saliva upwards into the oral cavity. So it is anti-gravity. It is supposed to push it up. So what will happen? The a tendency of the saliva to retain or residual saliva being left back in the gland is slightly higher as compared to parotid, which has to come downwards. So here it can trickle down easily, but here it has to be pumped out. So the chance of residual saliva is more in the submandibular gland. The submandibular gland is more viscous, the secretion, and it's more alkaline in nature. So all these 3 points are responsible for a higher incidence of sialolithiasis in the submandibular gland and a lesser incidence in the parotid gland. Now coming to the topic proper, or we get into the crux of the topic. Of course, whatever we read till now is equally important when we move ahead, when we talk about the surgeries, all right? So the most common indication for a parotid on this, for a surgery on the parotid gland is a neoplasm. Now this neoplasm might be benign, might be malignant. Again, benign also 80% of them are benign and about 20% are malignant. And when I spoke to you about lymph nodes, all right. So if you're doing a lymph node clearance and if you have to remove the superficial parotidectomy, that is also an indication for parotidectomy. So if there is metastasis from somewhere else which comes and sits on the parotid, and much more rarer indications for surgery are chronic parotitis, recurrent sialadenitis, where one particular procedure has failed. Can you tell me what that procedure is? Second years. Praveen, Nikita. Then Vinod.
Allography.
Huh?
Theolog-
For, see, sialadenitis has to happen because of repeated inflammation. If that inflammation
Yes, sir.
has to happen, there must be a stone. So,
Obstruction.
so that what is the procedure you do for removing stones? The most common
Si-
procedure.
Xylography.
Sialography is a diagnostic procedure, graphy, like ultrasonography. I am asking what is the procedure do to remove the stones?
Xyloplasty.
Hey, endoscopy.
Endoscopy.
Okay, endoscopic retrieval of the stones. Now, in spite of doing it and you are unable to remove it, let us say there is an impacted stone which is stuck deep in the parenchyma of the gland, even such scenarios are an indication for doing a parotidectomy. But like I said, invariably for calculi, the preferred treatment modality is endoscopy. So in this class, we're not talking about the pathologies. We are concentrating more on surgeries. But I'm just telling you that if endoscopy fails, then there is a role for parotidectomy even for non-tumorous condition. Okay, where there is neither a benign nor a malignant tumor, you might still have to remove the parotid gland. Now moving on to evaluation and investigation. First and foremost, history and clinical examination is of utmost importance. In that examination of oral cavity, in my opinion, is very important. Of course, the rest of it you already know, curtain sign, you're going to look, mobility, all that you're going to check. But why is oral cavity examination very important when we are talking about parotid glands?
About the deep lobe involvement, sir.
Pardon me?
To know about the deep lobe involvement.
Excellent. So what will you see if there is a deep lobe involvement?
Anterior tonsillar pillars will be medialized and uvula will be moved to opposite side.
Excellent. So basically the deep lobe is in something what we call as the parapharyngeal space. So if the deep lobe enlarges, it pushes all the structures medially. So your tonsillar fossa is pushed out. So when you see the tonsil, the ipsilateral or the area where the deep lobe is involved, the tonsil gets pushed out and even the uvula gets pushed to the opposite side. All right. So that is very important because now you're no longer just dealing with a superficial parotidectomy, but you're dealing with a deep parotidectomy. And of course, confirmation is using a bidigital examination, okay, from the outside behind the ramus of the mandible and from the inside, if you can feel the swelling moving, then it is more likely to be a deep lobe of the parotid being involved. And next important point is you need to know whether there is facial nerve involvement or not. And this is of utmost importance before you take up the patient for any particular procedure. Can you tell me why, Vinod? Whether it's a malignant, let us assume it's a malignant case. Why does this point become very, very important?
Sir, one is surgically, and second is post-surgery also medical legal things.
We are talking about surgery only. You never gave me any answer to my question.
Sir,
I am asking you, why is this point important, facial nerve?
sir, if it is involved, we will excise them even now. But if it is not involved, we will try to spare it.
Exactly. So there's something called as total parotidectomy and there's something called as total radical parotidectomy. All right. So I'll talk about it, but I'll just quickly run through it. Total means superficial and the deep lobe without the facial nerve. Total radical means superficial, facial nerve, deep lobe. Everything is taken off. Okay. And the only indication for that is if the facial nerve is involved preoperatively. Okay. So the facial nerve is involved preoperatively, then that becomes an indication for a total radical parotidectomy. And then, of course, you have to supplement your clinical diagnosis with the help of imaging and histopathology. Now, when it comes to imaging, the first investigation of choice is to do a ultrasound of that region or the head and neck, basically. One is that the ultrasound, most commonly, we are going to use this for benign swellings. Okay. Now, can you tell me what are the features of a benign swelling, Vinod? Benign parotid lesion?
In the ultrasound, sir, or
No, clinically, because you need to know whether it is benign or malignant, whether you want to get an ultrasound or a CT in your first shot.
slow growing and painless, soft to firm, nodular,
Anything else?
mobility.
Pain is one of the features. Then mobility is one of the features. And facial nerve involvement. Okay. That does not mean facial nerve is involved in all malignant cases. No. But if facial nerve is involved, it is more likely to be a malignant case. So USG has a decent specificity. Accuracy is also pretty okay. Now, the advantage with an ultrasound is that you can look at the vascularity of the gland. You can see whether the margins are regular or irregular. Echogenicity, whether it is hypo, hyper, or heterogeneous echogenicity. Then whether there is presence of microcalcifications. Just like thyroid and breast, the same features you can see even here. But one particular point is with regards to vascularity. Okay. Now, how will you differentiate a tumor from an inflammatory pathology of the parotid based on vascularity? Anyone?
It will
In
be
benign,
something
it will
like
be
neovascularity, sir.
Even inflammation also will have increased vascularity. How do you know whether it is neovascular or old vascular?
periphery to central, sir, in malignancies.
Okay. And in inflammatory?
Generally, it will be central to periphery because external carotid artery will be the vascularity to the parotid, which is inside the gland.
No, not like that. See, you're not looking at, this is important. Now, when you have a malignancy in a parotid, will it involve the entire parotid or will it be like a lesion within the parotid?
Lesion within.
Correct. So, if you have blood supply inside the lesion, okay, then it goes more in favor of a tumor. Whereas if you have blood supply around the lesion in the capsule, then it goes more in favor of inflammatory pathology. All right. So that is how you differentiate between a tumor versus benign pathology based on the ultrasound. But again, like I said, the ultrasound is not a very accurate modality of investigation for suspicious lesions. If it's a straightforward benign lesion, ultrasound is quite enough, and then you can move ahead with your treatment. But not so much if there is any role of suspicion or any doubt. Second is drawback. First and foremost, ultrasound is observer dependent. Second is that it cannot visualize the deep lobe. Okay, deep lobe can't be seen on the ultrasound. Can someone tell me why? If we can see superficial, why can't we see the deep lobe?
Because it goes beyond the mandible.
Yes, the ramus of the mandible comes in the way. So you'll have an acoustic shadowing, so you can't see what is beyond it. Okay. So because of the ramus of the mandible, the deep lobe is something that is normally not visualized. All right. Now, can you tell me what are the advances that are there in ultrasound? This is a bit extra for parotid imaging. With ultrasound, something extra.
Like high resolution, sir.
That is part of the ultrasound. That is basic only. That's not an advancement. One is you can use contrast. You have contrast ultrasounds nowadays.
3D ultrasound.
One more,
3D.
Elastography.
elastography. Now, contrast, I told you, idea is again to look at this to see whether vascularity is inside or from the periphery. That is where contrast will help. What about elastography? Do you think it's helpful or not?
More, the hardness will be more in the tumors which have more reflex.
Correct. I accept your point, but I will add another to it. I told you 80% of the tumors are pleomorphic adenoma, correct?
Yes.
And pleomorphic adenoma is such a tumor that in the name only, pleomorphic, it has varied histology.
Yeah.
So if the cells can change, can the consistency of the tumor also change?
Yes.
So if the consistency is up and down, can you depend on elastography?
No.
That's it. Okay. So if it's a straightforward hard mass, then you're outright, you know, it's a malignancy. But certain scenarios, a pleomorphic adenoma cannot be differentiated from a low grade, let us say mucoepidermoid carcinoma or even an adenoid cystic carcinoma sometimes, because of the fact that pleomorphic adenoma doesn't have one particular standard. It can vary up and down. So all these are points to tell you that ultrasound is not sufficient whenever you're dealing with anything beyond a straightforward benign lesion. Next is between CT and MRI. Okay. CT scan is low cost. When I say low cost, doesn't mean it is cheap. It is cheaper when compared to MRI. That's the only thing. And second is time. An MRI, I'm sure if somebody has undergone an MRI, you know, you have to be inside, let us say 20 to 30 minutes. CT scan is much faster. Let us say 2 or 3 minutes, you go in and you're going to get out. Okay. So it is faster, but again, the risk of radiation exposure is high. Whereas in MRI, the risk of radiation exposure is low. Okay. But cost is more, timing is more. So compliance is not that great. But the advantage is that if there is perineural spread, you can pick it up much better on an MRI as compared to the CT scan. So if given a choice, if they ask you which of the two you're going to choose, preferably an MRI. This becomes the investigation of choice unless you are suspecting bone involvement. If you're suspecting a bony involvement, then go in for a CECT. So I will stop at this point of time and take some comments before we go ahead, before we go into more controversies. Ravi Shankar sir, any comment regarding CT versus MRI, sir?
Yeah, I agree. I think I would still feel CECT is the investigation of choice. But if you are suspecting nerve involvement, then you ask for MRI. But because it also gives you additional information about the bone. I think most teachers, including Guru Shantap, also agreed that CECT is the investigation of choice. And MRI, when you are suspecting, it gives you definitely soft tissue delineation is better, perineural involvement is better. I think you should remember what the examiner's viewpoint is and answer that way.
Yeah. So, yes, sir.
Nishant, can I ask you what is
Yes,
the
sir.
software you are using for this class, because you are able to write, this
Sir,
is
good
very
notes, sir.
interesting. Huh?
Good notes, good notes.
Good notes, okay.
Uh,
So you prepared the presentation in that.
no, sir. Prepare it on a PPT, convert it to a PDF, and I'm writing on the PDF.
Okay, okay.
Yeah.
Okay.
So in short, guys, all you need to know is that both CT and an MRI are an equally accepted answer in your exam. And of course, you just have to justify saying MRI will give you better soft tissue delineation. CT will let you know more about the if there is an involvement of the bone, it will give you more information when you're doing a CT scan. Now moving on to a next controversial point. Do you have to do an FNAC? Now I'll get in the registrars, Sanya and Nitya.
Yes, sir. FNAC,
Why?
to determine the
I will give you one scenario from my side. If you're assuming that for malignancy, we are going to do total parotidectomy, that is not the truth. Whether it is pleomorphic adenoma or malignancy, the surgery you're going to do is to remove the tumor with a cuff of parotid around it. There is no margin. So whether it's a mucoepidermoid or pleomorphic adenoma in the superficial lobe, the treatment is still to do a superficial parotidectomy. I'm giving you the baseline. Now justify why do you think FNAC is important?
mm,
Next, Vinod.
No, it's no, sir.
Okay. See, this is a bit controversial. Some people say it is not necessary. Some people say it is. Now, the reason being, okay, the people who say it is not necessary, they say so because of the explanation that I gave you. Whether it is benign, whether it is malignant, there is no margin for parotid tumors. It has to be taken with a cuff of parotid around it. So for both, if we are going to do superficial parotidectomy, why do you want to do an FNAC? That is the first point. Second point is that you can't base your treatment just based on imaging. I told you that pleomorphic adenoma and low-grade malignant tumors look almost similar on imaging modality. All right. So in such a scenario, let us take out pleomorphic adenoma and replace it with Warden's tumor. Okay. Is there something called wait and watch policy for Warden's tumor? Can you observe a Warden's tumor, or all Warden's tumors have to be operated upon?
See, I always if the CSCP we said if the examiner asks a question like this, the answer has to be always yes.
Yes.
Otherwise, they won't ask that question.
Yeah, thank you, sir. So, see, a Warden's tumor, you can wait and watch. Now comes the dilemma. I told you that sometimes it becomes difficult to differentiate a benign tumor from a low-grade malignancy. Warden's tumor, you can wait and watch, but can you do the same thing even for a low-grade malignant tumor? You cannot. So that is the reason why they say FNAC is necessary. I wish Lakshman sir had joined because he said he had found some guidelines which said that it is not, but the guidelines which I found said that FNAC is a must. All right. So that is, I've put up the reference here. You can go and look it up. Okay. FNAC is a must, and I've told you the reason why I think it should be done. And whenever FNAC is inconclusive, then you're going to do a FNAB or your core needle biopsy, but normally we don't advise it. Most of the times you're going to get your answer with an FNAC and we're going to go ahead. Next is with regards to frozen section. How many of you vouch for frozen section?
Nishant,
Yes,
can
sir.
I just interrupt you? I'll ask the PGs, if you are doing an FNAC, what can make your yield better?
Correct. What is the preferred way of doing an FNAC in short?
Ultrasound guided, sir.
Yeah. So I think you should always qualify and say ultrasound guided, because as Nishant has said, the thing is, though the entire gland may be enlarged, if you on the ultrasound, you will be able to pick up areas which is likely to be, more pathologic compared to the rest of the gland. So it is better to biopsy that area, because even if there is low grade malignancy, you will pick it up on that. So always, whenever you say, I think straight away say ultrasound guided FNAC.
Correct, sir. Even I would agree with that.
Sir, the true cut biopsy is indicated sir, generally in parotid tumors.
No, only if you have a very suspicious, your FNAC is not very accurate and it's an elderly patient not fit for surgery. If you have a dilemma about operating, consider an FNAB, a true cut biopsy, in very rare circumstances, not in general. Okay. Next is regarding frozen section. Do you want to do frozen section in a case of parotid lesion or not?
I think
Nitya,
no,
go
sir.
ahead.
No, sir.
No, why?
Anyway, we are going to take the previous answer that you said that vouchers for this as well, sir. The ultimate minimum surgery that we do is a superficial parotidectomy.
Correct. Excellent. Just one addition to it. All of us are so only focused on parotid, we forgot about certain structures called lymph nodes in the neck. Okay. So pre-op, let us say even the FNAC is not clear whether it is benign or low-grade malignancy. You have gone in for the parotid. There only you're seeing one level 2 lymph node which is enlarged. You don't know whether that particular lymph node is malignant or benign. So you can remove that lymph node and send it for frozen section, not the parotid per se. Okay, parotid per se, it is of no use. But if the lymph node comes back as positive, that means you have to do a modified radical neck dissection. Okay, so frozen section is for lymph nodes rather than the parotid per se. Because my justification, be it benign, be it malignant, the treatment is the same. It's not going to change. Now coming to,
Nishant,
yes, sir.
can I just interrupt? There is another the extracapsular dissection, wide local excision of the parotid. If it's a small, tumor about less than 2 centimeters in size, in that, is there a role for frozen section?
I'm just coming to that, sir.
Yeah.
So the types of excision, just like what sir was telling, first one is extracapsular dissection. So basically what you're going to do here is you do not isolate and look for the facial nerve like how you do in a superficial parotidectomy. Your idea is to just remove a chunk of tissue. Okay. And the only indication is benign tumors. That means straightforward benign tumors, which are anything apart from pleomorphic adenoma. Except pleomorphic adenoma. Samir, can you tell me why? Why do
Samir,
we
come
not?
on, man, don't waste time.
Sir.
I
No,
Why do
asked,
sir.
we, what is so special about pleomorphic adenoma? Why is it something different from the rest of the benign tumors?
The
High
invaginate
recurrence,
capsule, sir.
high recurrence rate.
Because of
Capsular invagination.
pseudopods. Okay. So in such a scenario, it is not advisable to do an extracapsular dissection. So anything apart from that, let us say Warden's tumor or something, especially which is in the tail of the parotid, which is not close to the facial nerve, you can do an extracapsular dissection. The next surgery is the superficial parotidectomy or the partial parotidectomy. This is something that all of us know. Here we are
Nishant,
going to take, yes, sir.
just to interrupt, I think why you can't do it in the mixed parotid tumor or this one, apart from the pseudopods, I think recurrence rates are high with the the mixed parotid tumor, and also malignant transformation in mixed parotid tumor is also high. So with that in mind, you would not want to risk that. So that is why you would always recommend a superficial parotidectomy.
Yes, sir. So just to reiterate what sir was trying to tell you is that again, if there are the pseudopods and you leave something behind, there can be recurrence. And if you leave a pleomorphic adenoma like that only for a long period of time, it can become malignancy, and that is called as carcinoma ex pleomorphic adenoma. So it's not worth taking such a risk. So in such scenarios, do a superficial parotidectomy. Now, certain centers do practice doing this extracapsular dissection for pleomorphic adenoma, but let's not get into that. At your stage, if you answer that this is not done for pleomorphic adenoma, I think any examiner is going to accept it. Now, moving on, the most common surgery that is performed is a superficial parotidectomy. Here you're going to remove the superficial lobe. The next one is a total parotidectomy where you will remove superficial plus the deep lobe minus the facial nerve. That means you're going to leave the facial nerve behind. Okay. Do superficial parotidectomy, lift up the facial nerve, remove the deep lobe, leave the facial nerve behind and get out. And this is called as total parotidectomy. Total radical parotidectomy is superficial plus deep plus facial nerve. Okay. One indication we already know if the facial nerve is involved preoperatively. Can you tell me another indication? Vinod,
Sir, no idea. Sorry.
if the tumor is malignant and it is encapsulating the nerve, when you know that it is completely encapsulating the facial nerve, you have this information preoperatively. These are certain times where you have to do a a total radical parotidectomy. And in the same setting, you can even do a nerve graft, and the nerves I've already discussed, either the greater auricular nerve or the sural nerve. Okay. So this is regarding the various types of surgery. Any doubts or questions at this point? We will take them here and then go ahead.
No, sir.
Sir, I came across this terminology in Bailey, the recent edition, the adequate parotidectomy. How is that different from what we have discussed in superficial and the other total parotidectomy, sir? Like, I didn't understand reading that part of it.
Okay. Ravi Shankar sir, any inputs on this, sir? Because yes, sir,
I
please go
think
ahead
they
and
may
then I
be,
will.
yeah, I think they may be just alluding to extracapsular dissection. I don't think there is any, because I have read a lot of papers which actually now recommend extracapsular dissection for, specific indications, as you said, even for mixed parotid tumor, maybe in centers which are doing a lot of them. Otherwise, it will be, all benign tumors sans mixed parotid tumor. I think that is probably what they're alluding to as extracapsular dissection. Nishant, I have a small doubt.
Yes, sir.
When, let us say, you have done a total radical parotidectomy, you have sacrificed the facial nerve, but you have probably identified all the branches, right? You probably the zygomatic or the temporofacial, the big division, and then the cervicofacial division, and then you would have resected the facial nerve from where it is actually traversing the gland, and then use the graft from the origin up to these divisions. Is that right?
So usually, correct, sir. But usually what happens is this tumor involves the trunk of the facial nerve. That is when we do this radical parotidectomy,
Yeah,
where that pes anserinus is there.
yeah.
So the segment is very short where you have to do the anastomosis. If
Uh,
it's an individual branch, it's quite easy to sacrifice it and just connect that pes anserinus to that particular branch.
okay.
Rather than having from one area from it to going to 5 different areas, it is usually just one segment which has to be re-anastomosed.
Sir, if I can come in, adequate parotidectomy is a terminology which is being accepted recently, and they say it is probably will become the standard of care as management of parotid neoplasms. What they say is it incorporates facial nerve identification, tumor dissection, and removal with the surrounding healthy rim of parotid parenchyma, where they try to preserve the facial nerve, irrespective
Yeah,
of
that's
superficial or deep lobe involvement or both.
no,
So
that is
where
probably
you
a similar name to extracapsular dissection. That's all I think.
it is separate, not extracapsular dissection.
Okay, okay, fine.
Yes, sir. So going ahead now regarding steps of surgery. So of course, first one is you're going to give general anesthesia. Neck is turned to the opposite side. Head end elevation to reduce the congestion so that you're not going to have much of bleeding during surgery. Second is, and the last or the important point is draping. Can someone tell me how you're going to drape a patient when you're taking them up for parotidectomy?
Sir, in such a way that angle of mouth and eye should be visible during the procedure.
Which part of the eye?
Lateral.
Lateral canthus of eye, then angle of mouth, and the nasolabial fold.
Oh,
Okay. These three structures should be visualized. And why?
so
nerve
when we are
stimulator.
intraoperatively,
surface
the nerve is
marking.
Pardon
Answer
me?
one by one. For
Nikita,
some
go ahead.
reason, three
Uh,
of
Like
them
we
are
have
answered.
discussed, sir, surface markings to make sure that if you want to find out.
No.
Intraoperative nerve stimulator too.
Excellent.
Yeah.
Excellent. So idea is if you are in doubt to see whether this is a fibrous structure or a nerve, give using a nerve stimulator when you twitch or give a small stimulus, you can see the muscle twitching. That's the reason you need to expose half the face when you're doing a surgery. Don't use a whole towel and only keep this area open and operate. No, it has to be half the face. All right. So the lateral canthus of the eye, the nasolabial fold, the angle of the mouth, all three should be seen whenever you're draping the patient for parotidectomy. Now moving on to incision. This is the modified Blair's incision. All of us know what this is. Here you're going to have at least 2-finger breadth. That's also pretty straightforward to protect the marginal mandibular nerve. One important point is, another point is that before you make an incision, first draw your line where the incision is going to be. And we call this as scoring the incision. Can someone tell me why we do this?
That when you
the
close the, it
closing time
is
will
Abrupt.
helpful.
Yeah.
Sir.
Because it's not a straight incision, it's a curved incision. So the two halves are not equal. So if you don't know which edge goes to where, there is a chance you're going to end up with dog ear. And the idea is to get as much cosmesis as possible. Now, the second thing is that when you're having this incision which goes behind the ear, make sure you take a good generous curve. Don't go sharp like this or don't go very close to the ear lobule, because if you do that, you end up having what we call as a pixie ear deformity. You can see here the ear lobule kind of gets in attached or gets stuck up to the scar. So your ear lobule is not separate. So make sure you give an adequate or a decent amount of curve around that in the retroareolar region. Now,
Nishant,
yes, sir.
can I interrupt?
Yes, sir, please.
I think in English there is a this one. When somebody screws up anything, they say you made a pig's ear of it. So I think this actually probably is very appropriate in this case.
Yes, sir. So moving ahead, so this is the conventional modified Blair incision. You can see they've gone up and they've come down. Nowadays, they're saying, why do you even want to have this part of the incision in a cosmetic area? So they've come up with what we call as the facelift incision. In this incision, you're going to come in front and go back and run just adjacent to the hair all the way at the back. Okay. And then, of course, it makes the surgery a lot more difficult because you have to raise a big flap. But they say that if you can avoid this scar, let's try and do that. But this is just for you guys to know that there is an alternate way or a slightly more cosmetically appealing way of reaching the parotid, and that is called as a modified facelift incision. Then, of course, you're going to raise the flap. The best way is to identify the platysma in the neck and then go on lifting it upwards. And the plane should be between the parotid fascia and what we call as the SMAS, that is the superficial myoeponeurotic. I forgot what the S is. I think it is system, but I will cross check and let you know. Okay. So what happens is we know that in face we don't have subcutaneous.
Maybe it is strata, maybe.
No, sir. Something else. Can one of you just check on Google and let me know, please? Okay. So you're going to have your dermis, your epidermis, dermis, and we don't have subcutaneous fat in the face. The muscles of the facial expression are enveloped within a fascia, and that is called as the SMAS. So idea is be beneath that and just above the parotid fascia so that you're going to have a thick flap. Can someone tell me why we need to have a thick flap?
Sir, cutaneous innervation. If you take very thin, the nerves, the innervation will be lost. And one more is flap necrosis can happen.
Your cutaneous innervation was more appropriate. Idea is to prevent what we call as phrase syndrome. We'll talk about it once we get there. Complications, okay? So phrase syndrome is something that is very troublesome. We will talk about it. In order to avoid that, you need to have a thick flap.
You are right, it is system.
System, okay.
SMAs, yeah.
Okay. So then greater auricular nerve, we already discussed. You will sacrifice the anterior branch and preserve the posterior branch of the greater auricular nerve in order to get access. Now let's address the elephant in the room. So all of us keep worrying about facial nerve, facial nerve, facial nerve. The whole idea about parotid is to identify the facial nerve. Now, I've already put up the points here, and I will even tell it to you upfront. Okay, it makes it easier. See, idea is to identify the facial nerve. The most important point you need to know is that facial nerve doesn't traverse like this. Okay, it comes from the stylomastoid foramen. It comes outside and then takes a turn anteriorly. So any structure which is going completely horizontal from the external auditory meatus to the parotid is unlikely to be the facial nerve. Problem as a beginner is that every horizontal structure you're worried is the facial nerve. So idea is to get to the plane or the depth of the facial nerve. The best way of doing that is by identifying the digastric muscle. Okay. Lift up the tail of the parotid. You will find the digastric. The digastric runs and gets attached to the mastoid process, and that is in the same plane of the facial nerve. So anything superficial to that, you can cut. Okay, don't worry, you will not be damaging the facial nerve. Okay, anything above or superficial to the plane of the digastric can be cut. Only after you cut that will you reach the facial nerve. Next is this tragal pointer of Conley. 1 centimeter inferior, 1 centimeter anterior. Okay, inferior and anterior. That is where from the tragal pointer of Conley you will find the trunk of the facial nerve. Now there are certain points in literature which say that because it is a cartilaginous point, when you are dissecting, there is a chance you can have a fracture of this tragal pointer. Now, if it is fractured or dislocated, it can no longer be a reliable method for identifying the facial nerve. Okay. Now, it is no longer a fixed point. It is something that is broken, which can move up and down. So, this is also not considered as a reliable point. The most reliable point is your tympanomastoid suture. Most reliable indicator for facial nerve. The facial nerve runs just deep to the tympanomastoid suture. And remember, the tympanomastoid suture is palpated. Okay, you can't see it. You can only palpate the tympanomastoid suture, and just beneath that will be the facial nerve. Other point is your styloid process. Again, like how I told you with regards to the artery, vein, and the nerve. If you are seeing the styloid process, that means you have cut and gone across. Because what is more superficial is the mastoid, what is deeper is the styloid, and the nerve runs in between the two. So if you have seeing the styloid, that means you have cut through the nerve and you're looking at it. All right, so that can't be taken as a reliable point. Other one is to find the mastoid process. Now, the way of finding the mastoid process, either follow the sternocleidomastoid or the posterior belly of digastric. Both of them are going to go and get attached to the mastoid, and in and around that area, you will find the facial nerve. Last one, in very bad cases of, let us say, some scarring or recurrence when you're forced to operate, then you can choose a retrograde method. And I've told you, find the Zucker's point. That is where the buccal nerve will be there, and try to identify it backwards, which is not very easy. But these first 3 points will practically help you during surgery. First is find the plane of the facial nerve, and don't be afraid to cut anything that runs completely horizontal, because the nerve enters from inside and then takes a turn anteriorly. So this is an image of a patient who's undergone a deep parotidectomy. Here you can see this is the trunk of the facial nerve, 2 branches, all right? Then they're dividing. See, this is the digastric muscle. You can see they're in the same plane. and you can see this is the skin. So there is a lot of depth between the skin and the facial nerve. So for you to have the guts to cut all of this, you need to know that the digastric and the nerve are in the same plane. So anything superficial can be taken off. So this will be your tympanomastoid suture. Just beneath that is your facial nerve. Tragal pointer of Conley. Okay, sorry. This is the tragal pointer of Conley. 1 centimeter anterior, 1 centimeter inferior will be your trunk of the facial nerve. And what I kept saying, see, facial nerve doesn't run from there to here. No, from deep inside, it comes out and then runs anteriorly. Okay, so any structure which is completely horizontal like this, very unlikely to be the facial nerve. So before we go ahead, I'll just show you another image. I'll leave it there. Ravi Shankar sir, anything extra or Niranjan sir, anything extra to add for identification of facial nerve?
I think you've covered everything. And small point to add is if at all, especially in recurrent cases or in where there is definite evidence of nerve involvement or nerve encasement, you might want to use the nerve stimulator and take the help of it so that you can identify the nerve a bit more easily.
Niranjan sir, anything to add, sir?
Nothing, Nishant.
Okay. So once you have identified the facial nerve, all you have to do is take a blunt hemostat, gradually tease off the tissue on top of the nerve and use a bipolar. Why is it that we don't use a monopolar? Why only bipolar? Easy answer.
Lateral spread of current and that can
Correct.
cause an inadvertent injuries.
Yes. Lateral thermal spread is something that can cause injury to the nerves and can cause damage. All right. And like sir said, the other instrument which probably most of the high volume centers use and we don't use it because our numbers are not that great is the presence of a nerve stimulator. Okay. They use this compulsorily when they're doing an extra capsular dissection because that is somewhere where we don't identify or define the facial nerve. So whenever you're going to the deeper aspect of removing the tumor, you have to be careful that you're not chopping off a branch of the facial nerve along with the chunk of tissue.
Nishant, just go back to the picture, the last picture that you showed. See, I think all of you appreciate what Nishant said before. The retromandibular, can you see this one? See, the retromandibular vein is there. So, and you can see the nerve is superficial to that very clearly.
Yes, sir. So this was a surgery done by my friend Kush. He is from Ahmedabad. He is an oncosurgeon. So he had done this and shared it with me. So very nice dissection. Of course, oncosurgeons mean they bear everything. So which is probably not ideal always. So once you have gone on dissecting it along the facial nerve, you're going to get the entire flap of the parotid. It is going to come anteriorly like this. And the only other attachment is the Stenson's duct, where you're going to ligate it and you're going to what is that? Remove or what is it called? Transect the tissue there and remove the entire chunk. Important point again here, nerve injury, we have already covered it. You're worried about the buccal branch. Now moving on to the deep lobe. In case you have to do a total conservative parotidectomy, that means where you're going to leave the nerve behind. First half of the surgery is the same. Second half is you're going to put a simple loop around the facial nerve. Pick up the facial nerve, whatever is beneath you scrape out, that means take out the chunk of the deep lobe. Please remember, majority of the bulk is in the superficial lobe, not in the deep lobe. So in the deep lobe, the tissue is actually less. So pick up the trunk, clear off the deep lobe. If you want, you can even split the nerve in between the nerve branches, not split the nerve trunk, sorry. Wherever the branches of the nerve are there, you can even try and remove the tissue in between by splaying the nerve branches and getting the tissue out. If that is difficult because of scarring or some particular reason, there is one alternative approach called as the transcervical approach. We are going to incise the stylomandibular ligament. Now, this technique is predominantly used for getting to tumors in the parapharyngeal space. Most of the times you will be able to do it quite comfortably with this particular maneuver. But if you can't, that is when you're going to use this transcervical approach. Now, I told you your idea is to safeguard the nerve alone, but you will have to take the vessels. So can you tell me what are the vessels that we are going to ligate? Guys, very simple. Vinod.
Retromandable.
Hmm.
Will like it,
And
sir? Superficial temporal.
you might have to sometimes take the facial artery also. Okay, especially in the transcervical approach, if you're going to go, you might have to take the facial artery as well in order to gain access and remove the deep lobe of the parotid. Now, controversies. R0 versus R1 resection. Is there a role for R1 resection in parotid? We will get the registrars in here. Sanya or Nitya?
No, sir.
So do you think always an R0 resection has to be done?
Yes, sir.
Oh, you use the previous concept. If I ask a question, you should say yes, Santan.
No, I'm just thinking about it, sir.
No,
Yeah.
see,
All that.
please
No, but
understand
no, but
morbid.
you should have listened to the tone of his question.
Yeah,
Then you would have
conditions
answered
apply.
it correctly.
Yeah. See, the idea is morbidity associated with the facial nerve injury is extremely bad. Okay. So if the tumor is in close proximity to the facial nerve, don't assume that you have to take a chunk of tissue around it. Shave it off the facial nerve and give radiotherapy. Okay. But try and save the facial nerve as much as possible. So there is a role for R1 resection where you're going to shave it off the facial nerve. Second, we have a routine habit of irrigating that area after surgery and coming out. Do you think there is a role of irrigation in parotid surgeries to irrigate the wound?
Generally, in a malignancy, we tend to do it, sir. So I think that should apply here as well. Like,
I accept your view, but you are saying that in malignancy you're giving because the saline or something can kill off the cells. Is that what you're trying to tell me?
uh, basically, it was just to flush off that entire field.
I will put it to you in other way. I feel that if you put a lot of saline there, there is a chance you might, whatever is in one location, you might spread the tumor to all over because it's a big raw surface now, right? It's not just a
Yes,
bare surface. It's a raw, deep lobe of parotid that you're seeing. So I
yes,
put it to
sir.
you that there is a chance you might spread it everywhere.
But we are going to keep a drain, so it will come out.
No, what tumor seeding will
Tumor
happen.
cells,
Huh?
tumor cells will not drain.
Tumor cells will not come out. Tumor seeding can happen. So again, based on various literatures and what I spoke to 3 different head and neck surgeons, it is still controversial. Few people say you can do it, few people say it is not, but there is no conclusive proof that it either helps or it is detrimental to the patient. Okay. Last point before I get the seniors in is, do you think you need to use a suction drain? Yes or no?
No. No, sir.
They say that, see, because there's a raw surface, there is a chance you can have seroma. Then you're going to give, cosmetically, it's bad. You can have a sialoseal there. So routine placement of drain is recommended. Now, just for your exam purpose also, they might ask you, where are the other surgeries where routine use of drain is encouraged? Wherever you expect a lot of seroma to happen. Now, seroma or this collection will happen whenever you're disrupting some sort of lymphatic structures. So axillary dissection, neck dissection, groin dissection, 3 areas where routine drain placement is encouraged. And the only other exception to a lymph node surgery or a lymphatic surgery is the parotid surgery. So even in parotid, they do recommend usage of a drain except for extracapsular dissection, because there the raw surface is very small. So you can just put a pressure dressing. But if you have done a superficial parotidectomy, they recommend placing a drain, okay, for a few days so that you don't have a sialocele, and it also, the cosmesis is better so that there is no lifting up or collection of fluid in that region. Ravi Shankar sir and Niranjan sir, your inputs on this slide, sir.
I agree with all of you. I think all of the points that you made, irrigation, whether it is in relation to malignancy or in relation to infection. For example, when there is an appendicular abscess, it is said that you just suck out the pus and come out. The body will take care of it. If you irrigate it, then you are spreading the bacteria all over the peritoneal cavity. So I think the same principle applies here also. So probably, it is difficult. I think you will have to follow the principle or philosophy you use. No single correct answer for that. In terms of drain, I agree with you that I think it is, probably place it and take it out as soon as possible.
Niranjan sir?
Nothing to add, Nishant. You covered everything.
Yes. Sir, I probably will still need about half an hour to cover complications. So should I do it on another day? I can finish it off pretty quick next whenever it's free.
I think better to do it in another day. Complications, I think it is important not to rush.
10, 15. I think other thing is you have maintained the interest of everybody. I didn't even know you have already gone 1 hour 15 minutes. So I think it is a fantastic class, but attention span 45 minutes. So you already stretched it to 1 hour 15 minutes. So I think we'll go for the next class. I think.
Yes, sir.
Students.
Any doubts or questions with whatever we have covered so far?
What about now, sir, because of suction drains? Because we are doing the surgery around the nerve.
Nothing will happen.
Nothing is going to happen. You feel that the suction drain is going to cause neuropraxia or injury to the nerve?
Yes, sir.
If you're using a sharp instrument to dissect around the nerve, what will a blunt suction drain do?
But it is around 24 hours, it is pressing over the nerve.
If you think it is pressing over the nerve, take out the drain. Normally that doesn't happen. See, nerve compression, okay, for that to happen, you need to have a solid background, correct? Something pressing on a nerve, again, something solid. Only then will you have nerve compression. The nerve is nicely sitting on a bed of parotid. So it's like a mattress. So it'll actually absorb the pressure. This is what I feel based on common sense. I don't have evidence for this. I will look it up now that you have asked me this question. But I practically don't think that should be an issue.
Yes, sir.
Anything else?
That's all.
No. So thank you so much. And like I said, we will cover complications, very short class, probably we'll finish it off in about half an hour's time. And we will
I think
take the final.
You can probably combine that with submandibular gland so that I think it will be, both of them will converge nicely.
Sir, because here I'm concentrating more on Fraze syndrome. So because we have covered the anatomy here, it's better we finish it off in this, sir.
Yeah, agree.
That's why. Now,
Are there any comments?
Yeah.
Let's ask Sania to just give a comment on behalf of all the residents and registrars.
Very nice class, sir. Starting from anatomy and then telling about important points that we have to look into, and then going into the indications, and then for surgery. It was a very nice and detailed class, sir. Learned a lot.
Thank you.
So it was quite comprehensive and practical oriented and very nicely done. Thank you.
I apart from the content, which was exceptionally good, I was I think very impressed with this new methodology which I have not seen before. I think that is very, it actually stays with you. I think, and because you are writing it I think it will probably, the residents will also remember it very well. I think it was very good. Thank you.
Thank you, sir. So Nitya, please let me know when the next available date is, preferably
sir.
in the next 2-3 days, whenever it's free, we can just, like I said, a short class, even if it means we have to start early and finish it off, I'm ready to do that.
Okay, sir. Sure. I'll get back to you, sir.
Yes, please. Thank you so much.
Thank you, sir.
Thank you, everyone. Have a good night, and I'll see you guys soon.
Good night.
Good night. Thank
Good
you.
night.